Okay, good morning and good afternoon, everyone. Welcome to our webinar entitled The Final Common Rule, What Does It Mean for Health and Life Sciences Stakeholders? My name is Jian Chen. I am a partner in McDermott's Health Industry Advisory Practice Group based in DC. My practice includes working with a range of clients on various regulatory and strategic issues arising in the context of biomedical innovation and data sharing initiatives, and it's my pleasure to introduce you to today's program. I'll be joined today by two of my distinguished colleagues. The first is Bernadette Broccolo, a partner based in our Chicago office whose practice focuses on compliance and strategy considerations involved in implementing leading-edge collaborations, big data, and other digital health strategies to support innovations in healthcare delivery and payment, biomedical research, and precision medicine. And we'll also hear from Jennifer Geeter, a partner in our Health Industry Advisory Practice Group, also in DC, and her practice includes a range of issues attendant to biomedical innovation and digital health, including research strategy and compliance. Before we begin, just a couple of housekeeping matters. First, if you happen to have any audio issues with your computer during the program, there is a question mark box on the upper right-hand corner of your viewing page that will hopefully address most audio problems. But if you do have any persistent issues, please enter an inquiry into the Q&A section, and we'll get you some individual assistance. And in addition, if you're requesting CLE credit in the state of New York, please listen to the end of our presentation where we'll give you a credit code that's necessary to obtain CLE credit, and you'll have to enter that code on your post-program survey or evaluation in order to receive credit. And then finally, we hope you find this presentation engaging and that you'll have some questions. If you have any, just type it into the question box on your screen and hit submit. And we'll do our best to get to all of your questions either during or at the end of the program. And with that, I will kick it off to my colleague, Jen, to get us started.
Great. Hello, everybody. So we are here to talk about the much-awaited final rule of the Common Rule. As folks on the call probably know, the Common Rule gets its name from the fact that it has been commonly adopted by over 15 federal departments and agencies that look to this particular regulation to guide their agency-specific research compliance and oversight and enforcement activities. There hasn't been a material update since 1991, and it's been widely felt that the Common Rule was due for an upgrade given the changes that have taken place in research involving human subjects in the intervening decades. The effort that culminated in this final rule has been 5 years in the making. There was an advance notice of proposed rulemaking that garnered significant input and in many cases concern and criticism, and then a notice of proposed rulemaking that I think met with the same response. Both of those proposed rulemakings suggested wide-sweeping changes to the federal Common Rule. After this 5-year process with the version that was released, what we see is that most of the more aggressive proposals were ultimately not finalized in their proposed format. Nonetheless, there are some meaningful changes here, new categories, and significant attention paid to future use. And I think these changes give us a sense of where the agency is heading in future iterations. From a compliance perspective, the final rule in most cases will go into effect next January 19th. There is a delayed enforcement with respect to the IRB requirements around centralized IRBs. Now, there is a federal effort right now to have a pause and delay with respect to certain federal regulations to give the new administration time to review them and make sure they understand them and support them. And so these compliance dates could change. In addition, an agency can always issue new notice and comment if they want to make significant changes to a regulation that they don't think can be clarified through agency guidance. So it's possible that this rulemaking could begin again, but for now, these are the expected compliance dates. So what do we want to cover in the next hour? We want to make sure to go over some of the main changes on topics like the scope and jurisdictional enforcement of the Common Rule, some key changes in definitions that will help your institutions know when the Common Rule applies to their research efforts and when it does not, and how. Looking at some of the streamlining changes, a number of the new pieces of the Common Rule purport to make research oversight leaner and more tailored to the specific risks presented by different types of research. We want to go over some of those changes. We want to spend a good part of our time on consent and future use and new exempt categories. These are where you see most of the agency's efforts to think about what research oversight should look like for 21st century research, which includes more research that's data-driven and may not present the same balance of risks and benefits as traditional interventional research, and a focus on biospecimens and genomics. So how do we understand the changes at a high level? What seems to be motivating the final rule as it was released? Well, I think first, one thing that we see across a number of final rules, not just the Common Rule, was a push to have those final rules released in the last days of the prior administration. So some of what we probably are seeing is what the agency felt it could do in the time that it had. And this may explain why some of the more aggressive or disruptive changes to the way compliance is currently done were not followed through with. But there is an effort in the Common Rule to recognize there are real and lasting changes in the way that research is conducted, the emphasis on tissue and data, changes in technology. By that we mean, for example, whole genome sequencing and other types of digital health and life sciences technology that give new tools to researchers, but also present new risks and benefits that IRBs need to carefully consider. An emphasis on how we can collaborate on research, accelerate data sharing, and even more fundamentally, make sure we have the data and biospecimens at the ready in biorepositories for that future research. And thinking about what consent means in this modern research age, where the hallmarks of an individual's participation in a research study may not be an intervention, may not be predicated by a sit-down discussion with an investigator about informed consent, where the subject is increasingly the data or tissue from that individual. Okay, so when does the Common Rule apply? Here we have some interesting changes. First, in the prior iterations of the rule, the agency had considered extending the Common Rule to a broader scope of research. As you all know, the current Common Rule applies to research involving human subjects that's federally funded, and to research conducted at agencies that have made what we have always called a 4B election. They have indicated in response to question 4B on their federal-wide assurance that they agree to have the Common Rule and OHRP enforcement of the Common Rule apply regardless of funding. In prior iterations of the rule, the agency had looked to make the 4B election process almost more like a 4B mandatory process, where if you took any federal funds for human subjects research, you essentially then had to have the Common Rule apply universally. Instead, the final rule actually goes in the opposite direction. It does not maintain the current scope of the Common Rule. Instead, it retracts it. Specifically, it eliminates the 4B federal-wide election question. OHRP will no longer have oversight or enforcement authority over human subjects research without federal funding. And an institution cannot elect for the federal government to do that at its voluntary election. So from an institutional perspective, we see OHRP narrowing its focus to when federal dollars are in play. One place where jurisdiction seems to have expanded is with respect to independent IRBs. Those are IRBs that are not affiliated with an FWA holding institution. So for example, if you go out into the marketplace and you engage an IRB company, of which there are many, those are independent IRBs. They're not linked up with an academic medical center or a hospital, for example. OHRP will now have direct enforcement over those independent IRBs when they are engaged in research over which OHRP has jurisdiction. Many institutions that we work with have over time synced their human subject research compliance program for non-federally funded research with their program for their federally funded research, except in very specific situations that are particular to either federally funded research, like grant compliance, or non-federally funded research, like some of the financial relationship and conflict issues that come when you're working with an industry sponsor. In many respects, that would not change now. Even though the 4B election process is gone, institutions can still rely on internal policies and procedures to have a consistent standard across their institution. But they will have the ability to go in a different compliance direction than what the Common Rule recommends when they feel that that is appropriate and is not federally funded. Another change is a clarification to the definition of a human subject. In the proposed rule, the agency considered expanding the definition of a human subject to all biospecimens, even biospecimens that were not annotated with any identifying clinical data. The idea there was that the biospecimen itself, because of the presumably embedded genetic material, which is obviously unique to an individual, that the tissue or the blood or the other biospecimen was per se identifiable, and identifiability has always been, under the Common Rule, the hallmark of what makes an individual a human subject. They did not proceed with that definition. Rather, they clarified that the human subject definition includes biospecimens and data. The prior definition had talked about data alone. And they have intentionally and reinforced the fact that the biospecimens must be identifiable. And we'll see why that matters in a moment. So the original definition focused on obtaining data through intervention or interaction. And the new definition, you'll see under the purple bar, indicates that you have a human subject when a researcher obtains information or biospecimens through intervention or interaction. Now, there are new words there, but in many ways this is a clarification, because had you been doing research prior to the final rule that involved taking a blood draw or removing tissue or otherwise interacting with an individual, putting aside the identifiable data that did or didn't come from that, you would have had a human subject from the interaction, the intervention with them alone. But this clarifies that obtaining biospecimens through an interaction or intervention with the subject will require that you treat that individual as a human subject. And again, more clarifying language, when they obtain this information or biospecimens and then they use, study, or analyze that information, you would meet the first prong of the definition. Again, while there are some new words here, the conventional wisdom at this point is that the act of, for example, placing that information or those biospecimens into a repository would constitute a use. The second prong of the definition is the act of obtaining, using, studying, or analyzing identifiable information, even when there is no interaction or intervention. So we see these definitions as primarily clarifications. There's a lot of words on this slide. We want to just call out a few key points here. One is, what does it mean to be identifiable? And the key thing here is that something is going to be identifiable when the researcher can readily ascertain the identity. Now, when we're talking about data that includes standard identifiers, this phrase will have ready meaning. When we're talking about biospecimens alone, this essentially introduces a wait and see or evaluate as we go standard by the agency, so that the agency can consider over time those technologies that may be available to assist a researcher in making that ready assertion of identity. So, for example, there are two ways through this can happen. The first is that the Department of Health may issue guidance and sidestep formal rulemaking to continue to refine and alter this definition of identifiability. And second, the Department of Health can publish through notice and comment a list of technologies or other techniques that would necessarily generate information that the agency feels is identifiable. So both through guidance and through notice and comment, the agency can, over time, rather than doing it by fiat right up front, over time can indicate when they feel that tissue alone would be identifiable. And they've tipped their hand a little bit, and they've said that they think that whole genome sequencing is going to be one of the first that they would look at. Just quickly, there are some additional streamlining changes with respect to cooperative research, principally around incentivizing the use of a single IRB. There are a few limited exceptions, but they mostly go to situations where multiple IRBs would be required by law, or where the federal funding agency acknowledges that multi-site IRB oversight would be preferable. But the default is going to be moving to a single IRB for federally funded human subjects research. There are some additional streamlining changes. Some of these are going to come up in greater detail below, so I'm not going to go over them here. But I think what you see as you look at them collectively is that these are situations where once the study is up and running, continuing review may not be warranted because the risks and benefits are unlikely to change during the course of the study. The considerations around subject safety should be relatively static for these types of studies, and therefore the common rule would no longer require continuing review. The last major thing that I want to talk about, we'll do a quick hypothetical and then I'll turn it over to Diane, is the common rule is also starting to put its toe in this prep to research concept. So preparatory to research is a phrase that originates in the HIPAA privacy rule, and it's essentially activities that help researchers get ready or prepare for research. The HIPAA definition of preparatory research includes a broad array of activities: designing protocols, proof testing a research question, and helping to identify subjects who may be eligible for a particular clinical trial. The common rule definition is narrower. It is specifically focused on essentially pre-screening or subject identification to assist researchers in identifying individuals who may be eligible. So it's narrower than its HIPAA cousin. In addition, it takes a different approach. It requires that there be IRB oversight of those prep to research activities, although there need not be informed consent. Even though this would require the involvement of an IRB, the HIPAA prep to research pathway involves the researcher making certain representations to a designated official within the covered entity that the researcher is prepared to meet the HIPAA privacy rule obligations around prep to research. So I think what we can expect is that that designated official or committee or privacy oversight body for HIPAA prep to research may become the IRB, so that researchers are able to make a single submission when they want to do these pre-screening activities. This is one place where you see some effort to align and harmonize between HIPAA and the common rule, but as I mentioned, significant differences still remain. So just quickly doing a hypothetical to go over some of the things that we talked about. In this situation, a covered entity hospital is approached by an industry entity, a manufacturer, to serve as a research site. And the hospital anticipates that it may have some challenges with subject recruitment, so it wants to begin to administer a short questionnaire to patients who come in for certain procedures to determine their potential eligibility. This is already different in some ways than what we think of with HIPAA prep to research, which is usually on existing PHI, going through medical records or data mining. The OHRP definition includes reaching out to individuals, prospectively to gauge interest. And so the question here is, if the hospital is compliant with prep to research under HIPAA, does it have any other additional common rule requirements? Well, the first thing that we have to ask is the funding source. So if, in this case, the research is entirely industry funded, then the common rule isn't going to apply, and there aren't going to necessarily be any common rule obligations. But if, for whatever reason, there was federal funds that were implicated here, or if the entity had synced its requirements for non-federally funded research to the common rule, the common rule would require that prior to this questionnaire being distributed, an IRB be consulted and the process be consistent with IRB oversight. It wouldn't require patient consent, but it would require that the IRB looked at the questionnaire and was comfortable with that interaction. From a HIPAA perspective, you would have additional prep to research requirements, for example, not removing the data from the premises of the covered entity. Diane?
Thanks, Jen. So now we are going to spend a little bit of time talking about some of the notable changes that the final rule makes to the informed consent process, both with respect to just general requirements regarding the content and how information in an informed consent form has to be organized. And then we're going to spend a little bit of time talking about this new significant broad consent pathway that the final rule added. The notice of proposed rulemaking batted around a lot of proposed requirements regarding how to improve the understandability of informed consent forms and the informed consent process. There's been a lot of talk about, particularly among patient and subject stakeholder groups, that over time consent forms have just become unwieldy and overly complex and technical. And so the common rule, final rule, is an effort to address some of those concerns. And out of that came a requirement in the final rule that every consent now, going forward, has to include a beginning section that entails a concise and focused presentation of key information. What is a reasonable person going to want to know when they're being asked to participate in a research study? And merely just reciting facts is not really going to cut it under this new set of requirements. It really needs to facilitate meaningful informed consent and begin with key information that the individual is going to want to know. And note that the IRB is not going to be allowed to omit or alter this requirement. This kind of stage-setting requirement that HHS is now imposing on the consent process is so critical that it has to extend to all consent forms. The regulation itself does not specify exactly what has to go in this beginning section, but if you look at the preamble, you'll see a list of some elements that HHS would typically expect to see in that beginning section. Note also that for even the more complex, higher risk interventional clinical trials, this beginning section would be no more than a few pages. So just extrapolating from that, for some of the more simple, let's say retrospective data-focused studies, one could imagine that this beginning consent portion would be no more than a page or so. And you might also have some of the additional basic and additional elements of informed consent serve double duty in satisfying this beginning concise and focused presentation requirement. Note also that HHS walked back from its proposal that certain information be relegated to an appendix in a consent form. So what you have in the final rule is something that provides, as compared to the NPRM, a little bit more flexibility to researchers in designing their consent forms so long as they adhere to the understandability and new content requirements. So Jen mentioned how much of the final rule is an effort to bring the common rule in alignment with how technology and research has just evolved over the years. And if you look at the new elements of basic and additional informed consent, you'll see how this is playing out. So going forward, as a basic element of informed consent, there has to be a statement informing the individual that her identifiable specimens or information could be de-identified and then used or further distributed for other purposes without having to go back to the individual and obtain her additional informed consent. Alternatively, if this is not going to occur, the informed consent has to say so. So you see that OHARP is paying attention to the fact that just due to advances in technology, it's just so much easier nowadays to reuse and redact information and repurpose it for future studies. And so best that the consent form disclose that to individuals so that they can take that into consideration when they're being asked to participate in the study. Insofar as any biospecimen related study involves the generation of products or inventions that might have commercial value, the consent form also has to indicate whether or not the individual has a right to share in that commercial profit. There were a number of commenters to the NPRM who had apparently indicated an interest in sharing in the profits off of successful products that were developed with their specimens. And so this new requirement, which I think is more or less a codification of industry standard or industry practice anyway, now requires that consent form specifically states the individual is or is not going to share. If there are any plans or no plans to disclose back clinically relevant research results, the consent form also has to indicate that. And if it's known that a research study is going to involve whole genome sequencing or might involve whole genome sequencing, the consent form likewise has to indicate that as well. So you'll see that, as Jen was saying, given the changing nature of research and that in some cases it's no longer going to be a continuing interventional research study, consent forms really have to provide upfront information about the extent to which the individual is going to be contacted in the future by the researchers about how his or her information and biospecimens are going to be used and what the individual might be able to expect as a participant in the research study. And just an additional point regarding general changes to the informed consent process, note that there is now a new criteria relating to seeking IRB waiver of informed consent. This is something that's modeled after an existing waiver criteria in the HIPAA privacy rule that requires an investigator to demonstrate that not only is it impracticable to conduct the research without the waiver itself, but they also have to demonstrate that it would have been impracticable to do the research without the identifiers that they're seeking to use. So it's an effort to really encourage researchers to be mindful of the kinds of information and the kinds of identifiers that they're purporting to use in a research study, and to encourage them to use non-identifiable or more redacted information to the extent practicable. HHS also declined, notwithstanding, I think, several requests in response to the notice of proposed rulemaking to provide additional guidance on this much debated term practicably. Is that financial impracticability? Is it operational? Does it mean impossible? Is there a reasonable standard? Unfortunately, the agency didn't provide any additional color in that respect. So now we're going to talk about this new broad consent pathway that HHS included in the final rule. For those of you who are familiar with the prior version of the regulations, you'll note that this isn't an entirely new concept, right? Researchers have previously or already been able to obtain informed consent upfront for future secondary research use, sometimes unspecified future use. But now there is a specific pathway under the regulations that includes the provision of specific information to an individual about the biobanking and the secondary use of his or her information and specimens. And it's presented as an alternative by the agency to some of the pathways that are already available to researchers when it comes to creating biorepositories and making secondary uses of identifiable information and specimens. And we're going to talk about what some of the advantages and disadvantages of those pathways are. The new requirement, or new pathway, I should say, for obtaining broad consent is pretty specific. So if you look at some of the new elements that are required to be included in a broad consent, you'll see that due to the nature of the information that has to be disclosed, it might cause some individuals to perhaps be a little bit more reluctant to provide broad consent for the banking of their leftover specimens or their clinical data. Most notably, every broad consent would have to include a statement indicating that an individual is not going to be notified about the details of any specific research studies that might be conducted using her data or specimens. And that had she been notified, she might not have wanted to provide consent for some of those studies. So if that's going to be the case, the consent form has to disclose that. You'll also see that, like study-specific consents, broad consents also have to include statements regarding commercial profit, whether whole genome sequencing is going to be conducted, and as well as whether clinically relevant research results are going to be closed back. So none of these elements, in addition to the other elements of broad consent that are outlined in the regulations, can be omitted or altered by an IRB. So if a researcher wants to go down this route in order to obtain consent for biobanking and for secondary research use, they're going to have to adhere to the very specific and rigid requirements that are laid out in the regulations. Just some additional food for thought. Note that IRBs are allowed, in comparison, to omit or alter elements of study-specific consent. So query whether an institution or a researcher could develop a study-specific consent form that addresses biobanking and secondary use of information and specimens, which OHARP does say is still an option for researchers, but then seek IRB omission or alteration of the elements of that consent so that it's actually leaner than what a broad consent would be. The final rule doesn't really discuss this, and I think it remains to be seen how IRBs will interpret the restrictions and the interplay between study-specific consent forms and broad consent forms going forward. But it's just something to chew on as now you're evaluating your various options for creating repositories and engaging in secondary use. There are a number of pros and cons to consider when you're evaluating what approach to take from a consent perspective. I mentioned that the broad consent pathway is pretty rigid, right, and it requires the disclosure of some pretty important pieces of information that might results in perhaps a lower enrollment rate. But what are some of the advantages of obtaining broad consent? Well, the final rule includes a number of new and expanded exempt categories of research. Two of those exempt categories allow an investigator to conduct her research using more limited initial IRB review and to avoid continuing IRB review. And those categories relate to the storage and maintenance for the secondary research use of identifiable information and specimens. And in order to take advantage of those exempt categories, the researcher must have obtained broad consent in compliance with the requirements that I was just discussing. So whether that's going to be a sufficient carrot to counterbalance some of the downsides of obtaining broad consent remains to be seen. But it is perhaps for some that want to avoid ongoing administrative burden or to reduce administrative burden, that might make it a viable option. Note also that an IRB is not allowed to waive informed consent if an individual had been asked to provide broad consent, but then declined to do so. So if an investigator wants to go down this pathway, they're sort of tied to the mast, so to speak, in terms of the potential options that might be available down the line with respect to individuals that did not want to provide the requested broad consent. Just some additional thoughts here. It's interesting, the NPRM did ask commenters for feedback on the likelihood of their using a broad consent approach. And of the 30 or so commenters who responded, a majority of them did indicate that they likely would not use broad consent if other options were available. Something else to consider is, Jen mentioned that the final rule did adopt sort of a wait-and-see approach with respect to identifiability standards under the common rule. And so it's possible, although we don't know for sure, that the availability of this new broad consent pathway is perhaps in recognition of the fact that sometime in the future, with respect to perhaps certain types of genomic information or biospecimens, with de-identification out the door, that broad consent might be a more frequently utilized pathway for conducting research using those kinds of materials. But otherwise, I think it remains to be seen how eagerly researchers are going to be adopting this approach, and perhaps it'll continue to be a viable option for smaller types of studies or smaller biobanks, or for larger ones, it might still be sufficiently burdensome that it's not going to be something that's frequently used. Now we're going to use a hypothetical to illustrate some of the analysis that might be undertaken as an institution is considering developing a repository. So let's say that a hospital has some federal dollars available and would like to use it to create a biospecimen research repository using leftover specimens from clinical care. What are some of the pros and cons of its various options? For example, creating the repository using de-identified data and specimens, seeking IRB waiver, or if it wants it to be identifiable, what are some of the advantages and disadvantages of obtaining specific informed consent or broad informed consent? And there's a lot of script on here, but I think the main thing to consider here is that study-specific consent and broad consent continue to fare better than waiver and de-identification or coding when it comes to factors like patient relations considerations, being more mindful of individuals' interests in opting out or in having a say in how their information and biospecimens are used. Broad consent, as I was saying earlier, does factor in and is a criteria if the researcher wants to take advantage of some of the new exempt categories. But on the other hand, as with study-specific consent, it is, more costly and burdensome to obtain. And with study-specific consent in particular, there's going to be the need to have to revisit the consent form and potentially reconsent individuals if the original scope of the consent form does not encompass a particular downstream research study. With waiver, as with the de-identified approach, it's of course likely to be less costly and less burden going forward for the institution in terms of maintaining this regulatory pathway for the operation of the repository. But you have, the factor of not providing individuals with an option to not have their information and their specimens be included in the repository. So all of this is just to say that it's really important to be strategic and mindful of the various pros and cons of these regulatory options available for the creation of repositories and in pursuing secondary research uses. And note that the use of some of these pathways could also foreclose certain options down the line with regard to the pathways that are available for your secondary research uses of those specimens and information. So it's really important to be forward-looking in that respect and to take into consideration all of the advantages and disadvantages that coincide with these various options. And now I am going to turn it over to Bernadette.
Thank you very much, Diane. I am going to delve now into the overhaul and expansion of the exemption pathways. Jen introduced this as one of the new approaches under the Common Rule to try to streamline research and possibly bring things more into alignment not only with the changing research environment but also HIPAA. I want to point out that these are exemption pathways and it is not exclusion. Certain categories of exclusion had been proposed, such as excluding healthcare operations type studies altogether from the Common Rule. The exclusion recommendations were not adopted or proposals, but many of the themes or liberalizations of the Common Rule that might have been reflected in those have been incorporated into the exemptions. So what this means is that you're not, you don't have a, get out of jail free or you don't need to pass go. You have to go to the IRB. You have to get a limited initial review, and in many cases, if not all, you do not have to undergo continuing review for purposes of the Common Rule. And it will say, Jen and Diane have said, and I will say several times, to remember that just because you have more flexibility under the Common Rule doesn't mean you're all the way home on HIPAA, so don't forget to address both. The new and expanded exempt categories are particularly significant for secondary research and for entities regulated under HIPAA, and not only the research activities they conduct, but other things like healthcare operations. So there may be some liberalization there, but IRB review will still be required. Sorry, there we go. Thank you. So the overhaul and exemption of an expansion of the exemption pathways, as I mentioned, focuses very much on secondary research without consent, where certain requirements are met. And the first is probably the broadest and most flexible of these exemption pathways that require no Common Rule informed consent, and that is where the study involves the collection and analysis of identifiable private information, and it's regulated by HIPAA either as research, healthcare operations, or public health activities. Need to read this one closely because it does not involve collection and use of biospecimens. It simply relates to the collection and use of identifiable private information. that information can relate to biospecimens, but the research cannot involve biospecimens. The others really focus on very much on privacy type risks, as is true of a lot of the liberalizations in the final common rule. The one is that the information is already publicly available. The second is that it's recorded in a manner in which the identity can't be readily ascertained, and the researcher will not re-identify the subjects. And lastly, it's research conducted by or for a federal agency using information that was first collected for non-research purposes, where certain storage, maintenance, and compliance requirements are met. Again, the focus very largely here on privacy concerns. This new secondary research pathway recognizing HIPAA considerations and harmonizing or attempting to harmonize the common rule with HIPAA is welcome administrative burden relief for many HIPAA-regulated entities and for many organizations using identifiable information that was collected from covered entities. And again, as Jen and Diane have both mentioned, where we are in the new world of many studies involving just the use of data and no interaction with the individual and no intervention, the common rule is expressly recognizing here that the privacy risk is really the key risk, and in fact that it should be the HIPAA regulatory compliance scheme that comes into play in assessing the relative benefits of the study with the privacy risks. They still, again, here is exactly where you have to watch out for the trap. You're not home free simply because HIPAA applies. You have to still go through the hoops that you would have to go through. And as Jen, I think, mentioned before, or Diane, the IRB may be functioning essentially as a privacy board, or you may also have a privacy board, and so you may need to go to that privacy board, possibly the IRB, if, for example, your study requires a waiver. That's often going to be the case when you're looking to use data that has been previously collected, large quantities of data, using old clinical records, where it would be impracticable to obtain a HIPAA authorization from each patient. That's a common situation in which waiver is sought, and that would still be necessary. I think Diane's closing comments really key very much into several points to be made here with regard to this new broad consent category, and the significance of it is that if you obtain broad consent, when you don't have to go through all the same hoops, either for the creation of the repository or the secondary use of the repository. For many years, we have cautioned researchers to remember that the creation of the repository and the subsequent use of the repository are two separate compliance moments. This pathway for exemption and more limited IRB review and ongoing involvement very much keys off of that distinction or two compliance moments, and in fact really makes it more prominent and stressed by under the common rule, again now in a much more express way than has ever been done before, so there's no doubt that both are compliance moments. If you want to have this exemption pathway for the creation of the repository in the first place for a potential secondary use, which is, I think, in 100% of the cases, what you are dealing with, you need to obtain that broad consent. And then the IRB conducts only limited review to determine that it was obtained and that it was properly documented and that there are proper privacy and confidentiality protections in place, possibly similar to the way the IRB would have done before if a waiver was being sought. Then you will see that that first step of creating the repository for which you obtain broad consent is inextricably linked to your ability to use the exemption for secondary use of that repository going forward. All you need to do if the broad consent was obtained is to demonstrate that it was and to show that it was documented properly or that waiver of the documentation was given. And then again, the IRB simply conducts a limited review and confirms that the study falls within the exemption. I do want to go back to, I won't flip back to the slide, but I do want to go back over for you a couple of the things that Diane was alluding to and that come alive in the context of this exemption. It may have limited use at the current time in light of the more rigorous and more specific requirements concerning disclosure that are imposed in order to qualify for the broad consent exemption. That I note in particular that you need to inform the subject that it will either receive details about future specific research studies or a statement that they will not be so informed of such future uses, and most significantly that those future uses may be ones that the study subject may not have chosen to provide consent for if they had been aware of it. So this could be a deterrent to individuals being willing to give the broad consent. We have long heard from researchers looking to create and use repositories for secondary research that if many people don't consent either through an informed consent or HIPAA authorization up front, that less data or biospecimens may end up in the repository and it may not be valuable. So here you're going to have a balancing act. You have the burden of going through the process of getting the consent. You may have people refuse to give the consent, and as Diane noted, if they refuse to give the consent, you have to track that, and then you will not be able to even obtain a waiver to use that individual's information from the repository going forward. So it could be a catch-22, and what we have here is an important illustration of the fact that how you go about creating the repository and the compliance pathways that you use for the creation could have implications for the range and the flexibility of the ways in which you can use the repository going forward and what hoops you will have to go through. So the verdict is out on this one. I think the current view is that we probably will have limited use of this pathway going forward, and what that will mean is that you will be looking to some of the more traditional pathways that Diane and Jen have gone through, including most likely seeking a waiver and also considering use of the limited data set or de-identified pathways, both of which have some limitations, but for many studies may really streamline things more than this broad consent exemption is intended to accomplish. So the verdict is out. Let's talk about a couple of scenarios here to try to illustrate this. So here we have a hospital who is using federal funding to create a biospecimen research repository with leftover biospecimens obtained in the course of clinical care. Here the question is whether the new HIPAA-related exemption is available if the repository contains identifiable biospecimens. So here we have that first moment, the first compliance moment of creating the repository, and the creation of the repository is a study, and here it is a federally funded study. So the answer is that the common rule applies because the research involving only the collection of biospecimens and not only the collection of information. So you would not be able to avail yourself of the exemption here, and you would have to, as I just mentioned, start looking to some of those other pathways, maybe starting with consideration of broad consent and whether that would be helpful, whether study-specific consent is going to still be an option for you, and whether you should go for a waiver or use set it up so that there's a limited data set. But again, that's very, the waiver is probably going to be the most likely. The next example is a hospital wishing to conduct a research study using identifiable private information from a research registry. And here, it is only identifiable information, so even if the hospital was the same, using the repository, the biospecimen repository created in scenario 2, if it were only using the data, then that would be true, that would be the example we're dealing with. The registry was not federally funded when it was created, and there was no upfront consent obtained to do so. The hospital is considering whether to accept an offer to fund the study from a private source or to pursue federal funding for the study. So the hospital is considering what options it has to conduct the study, if it accepts the private grant, and what happens if it accepts the federal funding. So your source of funding can definitely drive what flexibility you have here. If the hospital accepts private funding, the common rule would not apply. The non-federally funded human subjects research is no longer subject to the common rule and OHARP oversight. As Jen pointed out, you could voluntarily subject yourself to it if all of your policies and procedures for all research follow the common rule, but you would not have to do so. If the hospital accepts federal funding, here it could use the HIPAA-regulated secondary research exemption to conduct the study without common rule consent or IRB review under the common rule. To comply with the HIPAA pathways, though, again, you would probably be seeking waivers, and as Diane mentioned, you probably have something akin to an institutional review board that is going to conduct some review. But again, it's more limited initial review, and the question of whether ongoing review would be required would really be subject to the rules of that of any oversight body involved in looking at this from a HIPAA perspective. So the decision to accept federal funding or not can definitely drive what flexibility you're going to have for this particular secondary study, and certainly whether to accept federal funding will be driven by a lot of other considerations. Couple of words of caution: distinguish between use of only identifiable information and use of biospecimens. Remember, you have to comply with both HIPAA and the common rule. I also caution you not to forget what can become the tail wagging the dog, and that is state law. Think of how you're creating a repository and how it's going to affect the subsequent uses. And things may be more complicated, as Diane pointed out, when the study, when you're involving a very large repository as opposed to a more small, confined one. And it will get even more complex when you're involving more than one particular player. When the institution or entity that created the repository is not the same one who will be using the repository, that subsequent user may have to do some due diligence to find out how the repository was created in the first place, who created it, what data is in it, what approvals were sought or exemptions were available, what waivers were obtained, what was broad consent used, and then if that first creator relied on the broad consent and the secondary user wants to piggyback onto that, there'll need to be some coordination between the two. in order for the secondary use to broad consent to apply. So your head may be spinning. It does require a lot of thought, possibly a flow chart. I think with that, I have concluded my overview, and I'll turn it back to Jen to wrap it up for us.
Thanks, Bernadette. This is Diane. I'll actually take it from here since we're at the top of the hour, and I want to make sure to give folks requesting CLE credit the code for purposes of New York. So that code is RED1, R-E-D-1, and you'll have to enter that into your evaluation in order to receive CLE credit. For all others that are requesting CLE credit, we'll be emailing you a certificate once this program is over. We'll also ask you to complete the program evaluation. We welcome any and all feedback and suggestions, and thank you again for joining us. We hope you found this useful. That concludes our program. Thanks so much.